We are about to start the Symposium on Tuberculosis, and the first lecture will be on novel diagnostics in tuberculosis. And I have the honor of inviting Professor Sanjeev Nair to deliver the lecture. He is attached to the Department of Pulmonary Medicine, Government Medical College in Trivandrum, and he is the present president of the prestigious APCCM India. Over to you.
Thank you, madam. Thank you, chairpersons. It's my first time in Sri Lanka, and I must thank Dr. Niranjan and the entire team for this opportunity to interact with all of you. Excellent hospitality and a very well organized event. Also, I should congratulate Dr. Niranjan on the excellent speech that he gave yesterday, which partly covered tuberculosis, also the situation in Sri Lanka, because one of my concerns when I was preparing for this talk was I would be largely speaking from an Indian perspective, and I was not really aware of the Sri Lankan situation, which I needed to know. So, thankfully, I was put in touch with some of the seniors today, and I could interact with them and learn a bit about it. I did read your guidelines, but that didn't really help me in that aspect. We move on. So, the plan for today is that I'll cover a bit of epidemiology, not because I want to speak on epidemiology, but because epidemiology is important. In tuberculosis, the tests are done based on public policy, public health policy, and it actually the epidemiology which determines what tests should be done in what scenario. I can give you an example. I was in a WHO training in India, and my previous boss in WHO, Dr. Fraser, was actually doing the training. And he was stuck in the training because a doctor from South Africa kept on insisting that India should be doing a culture for all the patients starting a second treatment. And this was the era when we were doing solid culture for everybody, and solid culture is limited capacity. Now, whatever Fraser tried to explain, he could not move ahead with the training. And then slowly he changed his strategy, and he asked me, Sanjeev, how many retreatment cases are there in India now? So how many patients do you treat for a second time? So I was taken by surprise because I wasn't expecting a question. They were debating, and why should a question come to me? So I said, probably around 250,000. So Fraser said, no, Sanjeev, you're outdated. 2 years you left your WHO job. It's 300,000 now. And this gentleman was talking, non-stop. Suddenly he became quiet. And then the training went on. And then while the training was going on, the South African gentleman slowly asked me, did you say 300,000? So I said, yeah, I said 300,000. And he said, boy, you have a problem. And that was the end of his discussion. So the numbers itself, determines what test you can do in a particular scenario. We'll also discuss a bit on how and the new tests came in and why they're needed. A bit on the issues in interpretation of these tests. So this is a slide that I keep using all the time. Most of us, Dr. Kandi or Dr. Luhadia would also be using this slide where you try to impress the fact that, India has a huge burden. 28% of the world TB scenario we have in India. It's a huge burden that we have. Of course, for this slide, I also added Sri Lanka. I knew Sri Lanka had less of TB, but then when I put the slide on, I was surprised by how low the numbers are. And your president actually very rightly pointed out yesterday that maybe a long time back, you did have a big problem here, but I must congratulate your entire country, pulmonologists and all the doctors here for this success, that your numbers are so low now that it's almost unbelievable. That, we had a discussion among all the South Asian countries today. None of the countries in South Asia, maybe Bhutan, I don't really know the statistics of Bhutan, but none of the other countries, be it Pakistan, be it India, be it Bangladesh, we don't have any numbers like this. So you have done a tremendous job in Sri Lanka, which also, leads to certain other issues with respect to the diagnosis. Now, India, recently we published our national TB prevalence study. So after a long time, we know how much of TB we have in India. And you can see that's a huge difference. At the top, you have Delhi and Uttar Pradesh, which is in the north of India. At the bottom, you have my state, Kerala. And if you compare Kerala to Uttar Pradesh has 5 times the number of cases as compared to Kerala. So 500 per 100,000, whereas Kerala is nearly 100 per 100,000. Now, you can't write off Uttar Pradesh because Uttar Pradesh is a province or a state in India, but it is more populous than all countries in the world except for the top 5. So there are only 5 countries in the world who have more population than Uttar Pradesh. It's as big as any other country in the world. So that is a huge burden that it carries for India. So I felt comparing Sri Lanka and India is not fair. So probably you should compare Sri Lanka with my state, Kerala. which is at the extreme south of India. In fact, when I was invited here, I looked at the map and it's just 350 kilometers from Trivandrum to Colombo. And they offered me a flight going via Delhi because that was the cheapest flight. So that I fly to 2,200 kilometers up north, and then I fly back 2,300 kilometers down south and travel 4,500 to come here when it's only 350 kilometers. So, I mean, so that is how life is. But then, when you compare the two states, it's quite similar, but slightly different as well. You have a bigger area, but we have a bigger population. A small state in Kerala has bigger population than you. Our numbers, I thought, should have been similar that before I came here, before I look at the statistics, but then you are doing much better than Kerala. So in India, Kerala is a state known for the best healthcare and, supposedly doing very well in TB, but then you are doing better than us. So again, congratulations to you. The other similarities are there. I didn't want to talk too much on that, but the similarities are we have a lot of diabetes. You have more of diabetes. Diabetes TB is a major problem. So many of the risk factors which come for TB are very similar between Kerala and Sri Lanka. So it goes like that. Strategies are evolving. I mean, all over the world, we are looking at moving from the stop TB to the end TB strategy. And the world is talking of TB elimination. You're not even talking of TB control. We are talking of TB elimination. And in that, we have very strict, stringent targets. Now, again, Dr. Niranjan's talk, if you heard yesterday carefully, the point he made was that you have made tremendous success, but it has plateaued now. So if you're going to eliminate TB, now you need a rapid progress. And that rapid progress would need a lot of new strategies. This is one of my favorite places in India, the National TB Institute, a picture from 20 years back when I had hair on my head. So at that time, this particular discussion in National TB Institute, we have a lot of academic discussion. And this discussion was happening. And my then boss in WHO, Dr. Fraser Weiss, is standing in that picture from UK. So he was all disappointed that particular day. And we were all upset. Fraser, we are doing so much for TB. Why are you upset? So Fraser said, if God comes in front of me right now and gives me 3 wishes, I'll ask, oh Lord, give me a new test. I'm working with tests which are more than 100 years old. So chest X-ray, all those tests are more than 100 years old. Then, oh Lord, give me a new drug because I'm working with drugs which are more than 50 years old. Last one, oh Lord, give me a new vaccine because the vaccine I'm working with is more than 100 years old. So for such an important disease like tuberculosis, you are working with drugs, tests and vaccine which are more than 100 years old, which actually needed to change. And thankfully for us, we got new diagnostics, we got new drugs, but vaccine we still are far behind. So these are the traditional tests, all of them more than 120, 130 years old. Still we are using them. It's not that we are given up on, you discuss so many diseases today, we are doing the latest of tests, but when it comes to tuberculosis, we still use 100-year-old tests. But then now, suddenly you have a huge spectrum of tests which are all very new. In fact, if from 2006 onwards, there's a rapid development of tests. And in fact, you feel sorry for those scientists who develop some of those tests because the test is developed, endorsed by WHO, very good test, but the test doesn't even get off the bench because somebody develops a better test. So then, that test just remains like that and doesn't get used at all. So we had a very interesting period. All these tests are available for us. I'm sure they are available for you in Sri Lanka as well. I'll go a bit into that. So first of these most important tests, which actually probably is the go-to test in tuberculosis today, are the nucleic acid amplification tests. So on the right, you have the gene expert, or the what we call in India, because we don't want to use a brand name there, we call it the cartridge-based nucleic acid amplification test, or CBNAT, which you have in Sri Lanka and you're using in Sri Lanka. On the side of that, you have the TrueNat, which is an indigenously developed test in India, developed by Mall Biotechnologies in Goa in India. So being India, issue of cost, issue of, importing kits and all always remains. So TrueNat is now being the favored test and being pushed. It is endorsed by WHO. It's not just that Indian test being used in India, and WHO is also endorsed it. Many countries are using it. So both these tests are available. And in the context of Sri Lanka, when your numbers are so low, and when the tests become costly, how do you actually justify the tests? I would say that these are multi-platform tests. I'm sure that you know that many of these tests, both these tests were used extensively for COVID. The tests can be used in MRSA. We're going to have a session on infection. Can be used for beta hemolytic streptococci. Can be used for Clostridium difficile. The TrueNat in our hospital is sitting and being used for hepatitis. So, it's not that it's just a test for TB. You can keep the platform and use it for various conditions. In fact, I don't know if Professor Dennis, Dr. David is here? No. He was always talking of fungus. I was thinking that, culture, developing capacity for fungal culture is very difficult. Maybe you should develop a nucleic acid amplification test for the fungus. Anyway, the tests are very good. They can give you a diagnosis of TB within 2 hours. That is not the only thing. Along with the diagnosis of TB, it will also tell you whether rifampicin resistance is there or not, which is a surrogate marker for MDR-TB. So you can actually start MDR-TB management immediately. And also the tests are quite good for extrapulmonary TB. So that is a major advantage we have. Now, at least India, we are moving towards making these tests upfront tests, So replacing smear microscopy completely with these nucleic acid amplification tests. Whether it's a good strategy or not, only time will tell, something to be debated. But the district where I come from, which is a population of about 3.5 million, all tests, the first test done is nucleic acid amplification test. No smear microscopy is done there anymore. So, things have moved on in that direction. You have cases like this where the X-ray, you can't make out much from the X-ray. So you go ahead with the CT because he had all the symptoms, including hemoptysis. And the CT also is not very remarkable. If you look very carefully at the bottom somewhere here, you can see a few nodules, very small nodules, which would lead to a lot of investigation in such a patient. But fortunately for us, the smear was negative, but the nucleic acid amplification test diagnosed TB, and the patient was treated and became okay. So it changed the way we looked at TB. Our diagnosis of TB really improved much more than smear microscopy. Also helps in a different way, So you have this patient whose clinical diagnosis was COPD. He was being managed, had some lesions in the upper lobe. CT was taken, not sure whether it's bulla or cavity or whatever. The smear came as positive. But one of the good things about the smear microscopy in the program is that the technician said, smear is positive for AFB, but doesn't look like Mycobacterium tuberculosis. The lab technician could say that. And the nucleic acid amplification test came negative. So, we had to evaluate further. And the microbiology department, if you look at it carefully, it's nocardia, it's a branching bacteria. So you can now, because of these negative NATs also will help you to rule out, look for non-tuberculous mycobacteria. Dr. Luhadia gave a very good talk. That is why I didn't keep an example of an NTM there. Line probe assay actually was the first test to come to us. Very interesting test. It's only that it takes more time than the nucleic acid amplification test that I mentioned earlier. It gives you lines on pieces of paper. The 2 tests are available, MTB-DR plus and MTB-TRSL, the first line and the second line probe assay. The first line gives you resistance to INH, rifampicin and ethionamide. The second line gives you resistance to fluoroquinolone, and second line are the injectable. So, you get a whole spectrum. So if you put your gene expert and the NAT and the LPA together, you get a spectrum of resistance, and you can actually determine regimes based on that. So there was something like 20 years back, I would complain to my students that if I was in USA, I would have known the resistance pattern to every TB patient that comes to me, and I would given them a proper regime based on the sensitivity testing, resistance testing. And here, today, we are able to do that in our country also because of these tests being available. The other test which came up in a big way is the liquid culture. If you remember Dr. Luhadia's talk earlier on NTM, it did talk of having a solid culture and a liquid culture. But then the fact is that, at least in India, we are moving towards liquid culture altogether. We've given up on solid culture, which is again a very important test, not a good thing that we are not doing that anymore. But anyway, these liquid culture machines have a major advantage. I don't know how many of you have seen a MDIT machine, but it's almost as big as this podium that is in front of me and can handle 960 samples at one time. So that is a major advantage. And it's a semi-automated machines tells you that this tube is positive, and then you have to take that test and tube and then evaluate further. It is relevant even when the molecular tests are there, because this is the only test which can tell you the viability of the bacteria. So if you do a nucleic acid amplification test in a patient on treatment, on follow-up, it will still keep coming as positive, so it will be misleading. So once the patient is on treatment, you might need a smear or a culture. And there are certain drugs for which resistance testing can be done only on your liquid culture. So you go to that. With so many tests being available, more and more tests keep coming, So you have whole genome sequencing, you have various variants of Gene Expert and variants of TrueNat. I'll not go into the variants of TrueNat because you don't have TrueNat here, but at least the variants of Gene Expert, the Gene Expert Ultra, the Gene Expert XTR, the Gene Expert Omni, all of them have various advantages and disadvantages. Time doesn't allow me to go there, but I'll only tell you that the Expert cartridge is something that we're eagerly looking forward, because that tells you a pattern of resistance to some other drugs, which will help us to determine very early whether our new regime, the BPAL regime, is appropriate or not. I'll not go too much into details of that. WHO has got a list of new tests, new technologies which are coming. It was a good, interesting slide for me earlier, but now having seen the epidemiology in Sri Lanka, most of these tests are looking at resistance testing, and your number of resistance is so low that maybe, some of these tests may not really be relevant to your country, even if they come. Of course, there are two good tests there, the TB LAMP and the, LAM, which can be tested, which actually helps in TB diagnosis. But again, these have been being developed for the last 20 years, still remains in the WHO list. I'm really not sure whether that will actually come out well. Now, based on all this, you have the algorithm for Sri Lanka, which I borrowed from your guideline, starting with, testing with your NAT and then going on to your line probe assay. If your first, NAT is showing rifampicin, not showing rifampicin resistance, you'll do your first line probe assay, pick up INS resistance. If your NAT is showing rifampicin resistance, you will test for fluoroquinolone resistance and then go further and manage the patient. But then your numbers are so low, so this algorithm, I'm not sure how much of relevance it is. India also, we have a very similar algorithm which looks at rifampicin resistance detected, where you do the further testing, including a first line probe assay, second line probe assay, a liquid culture for bedaquiline, pyrazinamide, linazol, and all that. And if rifampicin resistance is not detected, you do a first line probe assay and pick up INH resistance. Now, moving on, last bit on certain issues. I believe that the Ultra cartridge is being used in your country. One of its major advance on the Gene Expert cartridge, where it gives you more sensitivity because of the lower numbers being picked up. But then the increased sensitivity comes with a reduced specificity so that you can have false positives. So we had a lot of problems with false positives with Ultra. So that is something you have to be careful on. Extrapulmonary TB, my microbiologists are all excited about Ultra. But this Cochrane meta-analysis showed that if you do Ultra, you can have a large number of false positives, particularly in TB pleural effusion, which is what we deal with. I'll not go into details because shortage of time. But for extrapulmonary TB, a nucleic acid amplification test and culture has become the mandatory test, which helps you to find out that it's a genuine case of TB. And if those are not there, you end up making a clinical diagnosis. WHO analysis in the beginning in 2011 or 12 actually pointed out very good results for extrapulmonary TB with NAT. But in our practice, it didn't really come out to that extent. The numbers of extrapulmonary TB are increasing in our state and our country, but then I don't know the numbers here. I could not check that out for your country. But the problem is that the test doesn't get done. And when the test gets done, it probably has good results for lymph node TB and certain other forms of TB, but it has a low result for pleural effusion, which is something that we pulmonologists deal with a lot. I'll just tell you the fact that this particular nurse ended up in Delhi with a whole genome sequencing. Suddenly doctors in the private sector, many players are offering whole genome sequencing, and you end up with results like this where you have resistance to multiple drugs tested and you're not sure whether, because many of these technologies with whole genome sequencing are not really validated. Similarly, another case also, I'll skip that. Okay, I'm running out of time, but the elephant I saw in your major temple yesterday, it makes me, happy because we also see elephants like this in our temples in Kerala and in southern India. And this is the kind of elephant thing you have in Kerala, so the whole set of elephants standing there. One of our doctors in coordination with a vet found that many of the elephants in Kerala have tuberculosis. Now, what happens when elephants have tuberculosis and when they're blowing their trumpet on you with the crowds you can see there, what actually happens, which leads to a question of One Health, where, this particular child had a BCG, generalized BCG, that was a diagnosis, or is it TB? The NAT came as positive. Deers dying, spotted deer, I saw spotted deer in your Natural History Museum here. Spotted deers dying, autopsy showing cavitary lesions in the lung and the NAT coming as positive, MTB detected. So is it humans which are infecting the deer, or is it, something that is coming from the animal form? You have to remember that the NAT picks up MTB complex and not MTB. And BCG and Bowis are included in MTB complex, so that complicates the situation. So here you need to do an entire sequencing where we used to talk of 40 NTM earlier, now you have a list of 100, and any of these can actually turn out as positive. The last bit I'll say, we are having a lot of AI in chest X-ray, and chest X-ray reading is a skill we will lose, and AI in chest X-ray has come up in a big way. Some of these tools are very good, and in fact, they have been validated, and they found that these tools reading X-rays are better than your ordinary reader, almost as good as you and me. So their student will become better than us, so that, X-ray with handheld X-rays and, all those portable X-rays will make it better for us. Skip this BCG TB infection, 3 new antigens came, or one of which CT by TB is available for us. Sorry for exceeding time a bit. I'll conclude by saying the diagnosis of TB has now moved much beyond those traditional tests. Newer tests leads to better diagnosis of TB as well as quicker interpretation of drug resistance so that you can start drug resistant TB regimes early. Still newer tests are coming, so we really don't know where this will end and what all tests will we'll end up with. And to add to that, you have artificial intelligence and machine learning coming in, which will also complicate the situation further. Thank you for the patient listening.
Thank you, Professor Nair, for that excellent presentation. So the next lecture will be by Dr. Sangeetha Siniah from Malaysia, who will speak on inborn errors in immunity and tuberculosis disease in adults. She's a pediatric infectious diseases specialist and immunologist at the Tunku Aziza Women and Children's Hospital in Kuala Lumpur, Malaysia. Professor Siniah, you have 18 minutes.
Okay, hi. Thank you very much for the kind introduction. And I'm very happy to be here to speak to you all about a very important topic, which is inborn errors of immunity and tuberculosis in adults. Thank you again for allowing me to share a little bit more on this topic. So just to highlight, the outline of my presentation today will be a bit on background on what is inborn errors of immunity for those who have heard it for the first time. Then I will touch on IEI as the short form of inborn errors of immunity and tuberculosis in adults. And I will go on to speak on the common causes of IEI causing tuberculosis, a few cases, and how do you approach patients suspected with IEI in your setting. So these are a few of the adults with inborn errors of immunity who I have had the honor of managing. So a lot of them, as you can see, they look perfectly normal from the outside because what is missing is an immune component, which has either reduced in function or have malfunction. So they all look like normal individuals. So this is how they present with. Now, so just to give you a bit of a background, for those who would like to know, this is Malaysia. It has a West Malaysia as well as a island called Borneo. So I've had the pleasure of working in both areas. This is where I currently work, where it's the hospital Tunku Aziza. It's a women and children hospital, and it's a hospital complex where we have the adult hospitals, including the Respiratory Institute for adults nearby the hospital here. And when I was a very young junior medical officer, I was actually posted to the island of Borneo, where, as you can see, the terrains are very harsh. And, sometimes we need to take boats, we need to take helicopters. So just to give you an idea on the landscape of Malaysia. So moving on. So what exactly is inborn errors of immunity? So these are actually a group of primary immunodeficiencies, which was previously known or commonly known, and they consist of more than 450. In fact, these numbers have increased. Chronic conditions where a part of the body's immune system is missing or does not function correctly. Can adults get affected? Yes, most present at childhood, but however, some adults can present either at mid or older adulthood. So these includes patients with common variable immunodeficiency, or what is known as CVID, Good syndrome, autosomal recessive, chronic granulomatous disease, and MSMD. Some of this I will explain further in the next few slides. And why is it important in understanding IEI in adults? Well, for one, it gives a better diagnosis and better understanding into precision medicine. So, to summarize clinical immunology in a nutshell, it includes things which are called allergy, includes immunodeficiency. These words, if you have heard before, autoinflammation, autoimmunity, and also malignancy. So now, this is quite hot out of the press, I would say. So these are the report by the International Union of Immunological Societies. So most immunologists, we actually refer to this report, and this is updated every 2 years to tell you the latest genes which are involved in human inborn errors of immunity. So this is currently the 2024 update. And in this update, there are now 555 known genes of inborn errors of immunity. These variants, they alter the gene, they abolish or reduce the protein expression. And also some of the genes, they modify it by having like a gain of function mutation, which produces a different set of phenotype or a loss of function. To give you a better understanding, this is a graph from the previous report in 2022. At that point of time, there was again about more than 400 known genetic mutations, and these were categorized into 10 tables. And as you can see, these are the different tables which have been categorized, and they may present into any specialty, whether it's rheumatology, pulmonology, gastroenterology, whether it's infectious diseases, or even hematology. So almost all aspects of medicine, you may find a patient with inborn errors of immunity. So again, just to tell you that it is a table that shows you the common respiratory manifestations of primary immunodeficiencies, whether they are predominantly T cell defects, antibody defects, or a combined. And where we have tuberculosis as an infection, it is probably caused by infections caused by rare microorganisms. And where you have predominantly T cell deficiencies, immune dysregulation, where the immune system goes haywire, whether it's too high or too low, phagocytic disorders, and innate immune disorders. So now, coming to IEI and TB in adults. So what are the commonest causes and what are the types of PID which you look at? So the commonest would include combined immunodeficiencies, MSMD, which is also known as the Mendelian susceptibility to Mycobacterium disease, CGD or chronic granulomatous disease, and phenocopies of inborn errors of immunity. So I'll go through some of the cases later. And of course, please don't forget that when we have primary, we always try to rule out secondary as well. It's a very important cause, especially if you can't find, especially if you see a patient with tuberculosis and, persistent inflammation, or you can't solve the post-infection sequelae. So one important thing is HIV, malignancy, including lymphoma, leukemia, connective tissue disorders, and autoimmune and autoinflammatory diseases. So I always feel the best way to learn is through cases. And I will go through with you some of the cases which I have managed of patients with IEI and tuberculosis. So this is a case which was referred a 54-year-old male ambulance driver from the region of Borneo in Sarawak. So he was initially treated as a smear positive disseminated TB involving the lung, spleen, and bone marrow. Previously no family history to suggest an immunodeficiency. Throughout his treatment, he suddenly developed rashes and progressive anemia, lymphopenia, and thrombocytopenia, and he had recurrent admissions for a type of sepsis. Investigations revealed that his marrow was just hypercellular with increased histiocytes and some hemophagocytic activity. There was no excess blast. The second bone marrow had a hypercellular marrow, reduced erythropoiesis, no excess blast. And at this point of time, they thought that it was possibly a HLH triggered by tuberculosis. And his autoimmune screening was negative. Other infection markers were negative. And his basic PID workup, which was done, was normal. So, of course, at this point of time, they were still treating him as tuberculosis and possibly a HLH, but he did not fulfill the entire criteria for a HLH. And finally, when they did the third bone marrow for persistent pancytopenia, he had an excess of blast of more than 20%. So despite all the treatment and thinking that it could be a PID, the final diagnosis was acute myeloid leukemia. So the second case is another interesting case. It's a 21-year-old male from the city of Kuala Lumpur. He had severe COVID-19 Cat3, which he was given steroids. This was in 2020 during the height of COVID. Subsequently, he developed disseminated TB, smear negative, biliary PTB of the pleura, knee, liver, almost a lot of organs, including the CNS. And he was started on a good drugs, normal 4 drugs, anti-TB, which was drug sensitive since 2021. But the referral was made by the neurologist because he had persistent headaches and CNS tuberculoma. So a serial MRI brain and spine showed persistent tuberculoma despite him being on dexamethasone or methylpred. So what was very obvious that he was very steroid sensitive. So, of course, we went on to perform a few immunological investigations, for which we did a lymphocyte subset. We showed a low T cell, a normal B cell, CD4 and CD8, which is difficult to interpret. So the lymphocyte subsets sometimes are difficult to interpret because patients are on steroid. So generally, they will have some degree of lymphopenia. And however, we checked his immunoglobulins, which were all normal. So this gives a reason to have a combined immunodeficiency or an antibody deficiency a bit less. Dihydrorhodamine or DHR test to rule out chronic granulomatous disease was normal. An IGRA test was done, which was negative. I will explain to you why we did this. We even performed a whole exome sequencing to rule out any genetic causes of IEI, which was negative. And because we had one suspicion of an interferon gamma type of disease, that test was not sent. So one of the possible diagnoses that we thought of was this adult onset immunodeficiency with susceptibility to mycobacterium, which is an autoantibodies towards interferon gamma. So the points for were mycobacterium infection, normal B cells, and on immunoglobulin, which was responsive to steroids. The differential diagnosis of this was an MSMD because of the severity of the mycobacterium disease. However, usually they would have hypergamma, they would have family history, and usually they have a predilection towards non-tuberculous mycobacterium. The others would be other primary and secondary immunodeficiencies and an evolving malignancy. So just a bit of notes on this severe paradoxical reaction due to this anti-interferon gammas. Usually it is associated with what is called an adult onset immunodeficiencies. However, it is rarely seen in patients with Mycobacterium TB, and it is usually seen with patients with NTM. One of the tests that you can do is you can send an IGRA test, which is a kind of a test to tell you that possibly, if it is positive, that this patient may have this disease. But again, it is more with patients with NTM and certain fungus as well. So far in my practice, I've not seen anyone with TB have this disease. However, with NTM, yes, I have. So the treatment again will be optimizing the antitubercular therapy, steroids, and in some cases, there may be a need for immunosuppressive medications like rituximab. So the third case is a 16-year-old girl with a history of BCG lymphadenitis at 1 year old, needing IND. The younger sister also had BCG lymphadenitis and also the cousin sister, and a very strong family history of consanguinity. They were worked up for tuberculosis and was positive as smear positive TB. A few of the immunological investigations sent was fairly normal. And even a DHR test was negative for chronic granulomatous disease. And when we sent the genetic test, it actually came back as a Mendelian susceptibility to mycobacterium disease, IL-12B. So this is, again, from the IUIS classification. And from here, you can see that IL-12B deficiency is autosomal recessive, and it affects the function of the interferon gamma. So they have an increased risk of mycobacterium and salmonella. Again, it is a misnomer because we have a lot of patients with very severe salmonella infections, and this is salmonella non-typhi infections, as well as certain other viruses as well. They have recurrent infections, especially non-tuberculous, low virulent infections. Usually, there's a very strong family history of consanguinity, and investigations are usually genetics because most of the other basic screening are usually normal. The management is appropriate antimicrobial or antibacterial, which may have to be given much longer, and interferon gamma, which is also not available here in Malaysia. So if you have a patient, approach to a patient with suspected IEI with difficult to manage tuberculosis or with its complication. So the algorithm basically is, again, nothing beats a thorough history, including a family history, baseline immunological investigations, including a full blood count, a full blood picture, a lymphocyte subset. In Malaysia, we have the National Research Center, which we send to, or the universities. Serum immunoglobulin, which is at the regional labs, a DHR test or the dihydrorhodamine test, autoimmune screening, and plus minus a genetic screening to look for inborn errors of immunity. And of course, I would strongly advise for an early referral to a clinical immunologist. So just a little bit of sharing. So since we have started the adult immunology clinics, where I've taken a lot of referrals from the National Referral Center, most of them have been from respiratory. And I think these numbers, for the last few years, has been increasing as there is greater awareness and people are picking up, especially the difficult to treat tuberculosis. Having said that, not all of them have a genetic diagnosis. Most of them are actually a complication of the TB itself, including severe TB iris. So, hence we work closely with the primary team, especially with the neurologists, respiratory physicians, to better help the patients as well. So moving forward, in Malaysia, what we do is we have tried to get our adult counterparts to be interested in immunology. We would love to have a transition of care, research collaboration, and to start running immunology clinics with adults together with our adult counterparts. So what I've done is I've started some visiting clinic at the Respiratory Institute, the Adult Respiratory Institute, as well as some visiting clinics in the island of Borneo in Sarawak, where I see both adult and pediatric cases as well. So with that, I would like to thank you very much. And all this would not be possible without my wonderful mentors, especially where I trained my immunology training with Prof. Sujit Singh and team at PGI Chandigarh and the rest. Thank you very much. Thank you.
Thank you very much for that excellent lecture. We will be taking questions at the end of the next lecture. I hope you will be there. Thank you.
I have the privilege of inviting Professor Sanjeev Nair again for the lecture on therapeutic advances in tuberculosis.
Thank you, madam. I exceeded a bit of time earlier, so I think it's my duty to catch up on time so that I give time back to the organizer. The plan earlier was to discuss evolution of how the drugs, actually the groupings changed and how the regimes changed over the years before I reach the newer regimes. But I think if I do that again, I might run out of time. So I'm going to skip that part of it. I'll directly go to the newer regimes, the trials which went into the newer regimes, and how that is being translated to policy in various parts of the world. So I'll skip that initial introduction part and directly jump to them. Now, these are or were the current regimes which are happening in India. It would be slightly different in Sri Lanka because India, there is a lot of resistance. So, INH resistance is to the tune of 13%. Fluoroquinolone resistance in MDR TB in certain parts of India is to the tune of 50%. There was also the anticipated side effects to various drugs. So the Indian program was proactive in adding more drugs to its regime. So the first one, for example, the drug-sensitive TB, you need only 3 drugs in the intensive phase, INH, rifampicin, and pyrazinamide. And then you need INH and rifampicin in the continuation phase, which is what WHO recommends. But in India, we have ethambutol added there. Similarly, if you look at the regime at the bottom, again, if you go by your country guidelines, you have only 4 drugs in the intensive phase and 3 in the continuation phase for the longer MDR regime. Whereas in India, we added 5 in the intensive phase and 4 in the continuation phase because of anticipated resistance and side effects. Anyway, so these are the kind of regimes you are all familiar with it. These are the regimes in your program as well as in my program. But then we are all, never happy with what is happening, and we always want more. So despite all these drugs, despite bedaquiline and all the good drugs being available, our success rates often are not very good, and you want to further improve treatment for your patient by reducing the pill burden, by having safer drugs, cutting short the duration further. So, when your patient comes to you and says, what treatment will you give me? You say, I'll give you short course chemotherapy. So the patient thinks you're going to treat me for 3 days or a week. And then he or she understands that short course is minimum of 6 months. So 6 months by nobody's imagination is a short course treatment. It's a long treatment. And then when it comes to MDR TB, you're treating for 18 months, 20 months. That's pretty long. I mean, how does a patient do it? So always the desire is make it shorter, make it easier for the patients. And also do that without having any relapses. So you need a relapse-free cure and also with minimal side effects. So with that you want to look at new regimes. Of course, after the advent of bedaquiline, the success rates have improved, but still you want further reduction in duration of regime. So, one by one, we'll just go through 3 or 4 studies which actually looked at shortening regime. So the first one was drug-sensitive TB, where there is no rifampicin resistance. So here, the idea was to do a 4-month rather than the 6-month regime. So you're looking at minimum treatment of TB until recently was considered as 6 months. Now you're looking at a 4-month regime. And then you're looking at, a certain group of drugs, new drugs to be added. So you are having rifampicin and moxifloxacin added to the regime, and then you're trying to do it. So they tried 2 different arms. One was with isoniazid, rifampicin, pyrazinamide, and ethambutol, and the other limb was with isoniazid, rifampicin, pyrazinamide, and moxifloxacin. And both these arms were compared with the traditional regime, 6-month regime that was already being used, and you looked at the efficacy of these regime. And you find that the moxiflox rifampicin containing regime, so the INH, rifampicin, moxifloxacin, and pyrazinamide regime actually meant the non-inferiority endpoints. And they found that 4 months of treatment with that regime is non-inferior to the current regime that you have. Whereas the other regime where they just, substituted moxifloxacin, it did not work. It crossed the inferiority limits, as you can see in those 95% CI shown there. So that regime was found not to be effective. So the conclusion was that you don't have to treat for 6 months. You could actually treat for 4 months and, treat drug-sensitive TB. But if you look at it, this is a study, for the younger people, if you've not read this particular study, do download it and read it. It's quite interesting. You should discuss it in your journal club, because at the end of the day, if you look at the survival graphs, you will see that still the control is better than the experimental limb, and it's something to be debated. Anyway, that was a study which actually showed that 4 months is good enough. Then you had the next study, which looked at a very difficult group of MDR TB patients. So, you're looking at XDR TB patients whom we were kind of writing off at one point, and then the MDR TB who are non-responsive to treatment. So these were not your ordinary MDR patients. You're looking at a group of MDR patients who are difficult to treat in the very beginning. They're either XDR or not responding to treatment. And there you tried a regime with new drugs, again, bedaquiline, pretomanid, and linezolid. And to the surprise, the success rates in both these regimes were like 89% and 92% for 89 for XDR and 92 for treatment non-responsive. Again, extremely impressive as what you do expect in these very difficult groups of patients. So this actually, made everybody wonder, can you treat by 6 months of treatment for XDR TB and MDR TB and still get such high success rates? So that is something that came up. The only other side of the story is that with the dosage of linezolid they used about 1,200 milligram of linezolid in that particular regime in the beginning in the next study, and almost everybody had a side effect, and they had very severe side effects to linezolid. So they felt that, okay, you cannot give such high doses of linezolid, and to follow that, they brought up with the new study called the ZNIX study, which actually looked at various doses of linezolid. Can you give different durations and doses of linezolid and get away with those side effects which actually happened in the next study. So you had 4 limbs here, and each of these limbs looked at 1,200 milligram of linezolid given totally for the 6 months, 26 weeks, 1,200 given for the initial period only for 9 weeks and then not given further. Then you had 600 milligram of linezolid given throughout for the 26 weeks and 600 milligram for 9 weeks. And of the 4 limbs, they found that giving 600 milligram of linezolid along with bedaquiline and pitomanid was the best possible alternative with the best efficacy rate. So again, they could work out this is the dosage of linezolid which works out best in patients. Because in the meantime, MSF and other partners actually did a study called the TB Practical study, which was actually in an MDR TB group, which was not resistant to fluoroquinolone. So this is a better group than what was studied in the next study. And in this particular group, they tried out various regimes, 3 different regimes in fact, but they found that the BPAL-M regime, that is the bedaquiline, pitomanid, linezolid and moxifloxacin regime gave excellent results as compared to the traditional results which were being got at that time. So at that time, you were actually giving injectable containing MDR TB regimes, which are giving only a 52% success. So here, you could actually give a new regime just for 6 months when the other regime was for 2 years. You're treating only for 6 months and you can give 89% success. So again, these 2 studies, the NIX, the ZNIX and the practical study, 3 put together, made the whole world wake up and think that you don't have to give like 2 years, 3 years of treatment for MDR TB. You don't have to give those injectables and all. You give lesser number of drugs. You're giving only 3 drugs. Earlier, MDR TB, when you took a class for MDR TB for students, you would say more drugs in the intensive phase, the better. If it's say 7 drugs are better than 6, so number of drugs would be high. But here, by giving a small number of drugs, 3 drugs or 4 drugs, you're getting equally good results, and the efficacy was shown, again, replicated elsewhere. Of course, we had a similar study in India where we looked at the BEAT study, which looked at bedaquiline, delamenil, linezolid, and clofazimine. From the India perspective, this is interesting because it does not have a fluoroquinolone. In India, we have a lot of fluoroquinolone resistance, almost to the tune of 50% in some of our states like Maharashtra and Uttar Pradesh. So those fluoroquinolone-containing regimes may not really work well, and you have a regime like this. Again, the response is quite good when the patient does not have resistance to any of the second-line drugs, but if there is fluoroquinolone and second-line injectable resistance, the success rate comes down. But again, 91% success with the 6 to 9 month regime was spectacular. So now you have a set of studies where the evidence has come out that you could treat drug-sensitive TB in 4 months and drug-resistant TB in 6 months by using a particular combination of drugs. So that is the evidence that came out. And very soon the evidence was put into policy by WHO. WHO, of late, so many changes are coming. I mean, I feel sorry for my residents, So I remember one of my young residents, I had asked too many questions to her and she got all upset that she could not answer me. So that particular night, she went and read the entire Indian guideline, So she read the guideline document and came to me next morning and said, "Sir, I'm prepared today. You can ask me anything." So I said, "What did you read?" So I read the Indian guideline. So I said, "Where did you get it from?" I got it from the website. I said, no, that is changing. Tomorrow, new one is going to come. And you should have seen that lady's face. She had studied a 150-page document and come just to find out that the new version was about to be released in a few weeks' time. So that is how fast it goes. And WHO doesn't even have time to bring out new guidelines. So what is happening is they bring out these short communications, rapid communications, and only short parts of policy are put into the document and it is released here. So here, the rapid communication with respect to drug-sensitive TB said that, a shorter regime of 4 months, which I mentioned earlier, giving INH, rifampicin, pyrazinamide and moxifloxacin is good enough to treat your patients. And for MDR TB, it actually gave you the other regimes. Now, CDC Atlanta also came out immediately with a guidance saying that you can actually treat drug-sensitive TB, conditional with certain problems not being their age group and other things being okay, you can actually treat them with a 4-month regime. And you must have read WHO also coming out with the guidance that you can treat MDR TB with shorter regimes of 6 months. The BPAL regime and the BPAL-M regimes were actually endorsed by WHO. The shorter regime that we were using in the program, if you noted that, the 9 to 11 month regime has also been modified a bit by WHO. Earlier in the shorter regime, we used to have in the first 4 months, in the 7 drugs, we used to have ethionamide. That was changed to linezolid for just 2 months in the intensive phase of that shorter 9 to 11 month regime. So these were the changes which came in the WHO short communication. So that, the whole thing, countries are forced to bring about change because internationally change has come. So if you look at India today, our drug-sensitive TB still remains the same. The INH-resistant TB regime also remains the same. But when it comes to MDR TB, the preferred regime today, the guidelines have been released, the training is ongoing, drugs have been procured, but we still haven't, we're just starting to administer to patients. But the preferred regime, if all the other contraindications and other things are not there, is a BPAL regime for 6 months, BPAL-M regime for 6 months. And then for certain reasons, if you're not able to give that regime, then you will either go to a shorter regime, which is the 9 to 11 month regime, with a change that linezolid is given instead of ethionamide for 2 months. Linezolid was for 4 months, ethionamide was for 4 months. Now you're giving linezolid for 2 months, midazolam for 6 months of the entire regime, and the other drugs as were there earlier. And even if that is not possible, then you might have an individualized longer regime for 18 to 20 months. So this is the current policy in India, which is already the new guideline document has been released. So the Sri Lankan document also talks about the future of moving on to BPAL and the BPAL-M regime. I understand that we are yet to reach that stage in Sri Lanka. So I think that is how it actually goes. December, this is about 2 months, 1.5 months back, IDSA, ATS and everyone has come out with a new recommendation on drug-sensitive and drug-resistant TB. And now this reads like this. So this is the latest IDSA ATS ERS consensus, where drug-susceptible TB, the regime is for 4 months, with INH, rifampicin, pyrazinamide, and oxyfloxacin. For drug-resistant TB, for MDR TB, if you look at it below, MDR TB, if you have fluoroquinolone resistance along with the MDR TB, the regime is a BPAL-M regime where you're giving bedaquiline, pretomanid, and linezolid for 6 months. Whereas if the MDR TB does not have a fluoroquinolone resistance is not detected, you give a BPAL-M regime. So this is how it goes. For a country like India, of course, the main difference from this would be the initial regime for drug-susceptible TB, where we still are going with the traditional regime. You should understand that India treats 25 lakh or 2.5 million cases every year. So, 2.5 million cases, if you move to this newer regime with rifampicin and moxifloxacin, this will really push up costs. And rifampicin is not that readily available also to treat like 2.5 million patients. So, India definitely, I think, for drug-sensitive TB would not be able to move to that particular regime. But for drug-resistant TB, as I told you earlier, the move has happened. So since many countries are moving, sooner or later, I think Sri Lanka would also be moving to the BPAL and BPAL-M regimes. The other regime, the initial drug-sensitive TB regime, again, will depend on the economics of your country and the access to drugs, whether you're able to spend that much money for drug-sensitive TB, and also whether you have access to rifampicin and other drugs. That is not the end of it. There are so many new drugs being developed. The drug pipeline is very active with so many drugs in phase 1, phase 2, and phase 3. And some of them, we are looking very eagerly towards sutazolid, which we have been told that in South Africa has given very good results. So, many new drugs will come. So this might even change further. So that is a lot of excitement for the future. So the availability of newer drugs and newer regimes coming out well in trials has led to the formulation of new regimes for TB, and the older regimes are considered less effective and more toxic, so that you're all moving to new regimes. WHO has put guidance in place. ERS, ATS has also put guidance in place. It's a question of whether countries like ours can actually accept it and afford it. So that is what will determine the regimes in our country in the future. Thank you. So I saved a bit of time on that.
Thank you so much for that excellent lecture, Sanjay. You really did a wonderful job in the short period of time. Now the forum is open for questions. There are 3 microphones. Please come up and ask your questions.
Thank you, Sanjeev. Actually, it's not a question, a comment on your first talk on the diagnostics. The government of India moving for molecular test upfront. I have a strong reservation. In fact, I wrote to the government of India. So you have told there are two conditions. If you don't do sputum, we'll miss. We have a big problem of non-tuberculous mycobacteria. So if you do away with the sputum, we'll miss those cases. Yesterday, and one more, no cardiosis also, we have given an example. This is for countries like South Africa, you can do for a upfront. And India, I have my own reservations for going upfront CBNAT test.
So I think Professor Kandi's comment is well taken. So there's a concern that we all have. So one is Dr. Luhadia's talk earlier. So in India, as of now, we suspect that the patient might be having non-tuberculous mycobacteria. When the smear AFB comes as positive and the nucleic acid amplification test shows that MTB is not detected. Now, if you stop doing the smear or AFB altogether, then you will now not be diagnosing NTM at all. But then I think NTM has never been a concern of the programs. TB programs have never been really concerned about NTM. More than that, I think what I was discussing with Madam earlier is that at least one of the NATs that we use is not an indigenous machine. It comes from outside. So one never knows with the political atmosphere, the economic atmosphere changing. Suddenly we might find ourselves without cartridges, and we might find that all our microscopy labs are also closed, and then we might be in trouble. So at least in India, we have two, we are not placed all our eggs in one basket. So we have two tests, the Gene Expert as well as the True NAT. So because both tests are there, probably we'll be able to cover for it. I think it's a question of national policy. You want to pick up cases early. You don't want to do a smear, then wait and do the next test and all that. And you want to pick up resistance early to bring down mortality. So in public health, you can always debate on strategies. There will always be pros and cons on
that. May I ask a question? Now you are going, is India going to go for the shorter?
This is regarding your second talk on moving to the shorter regime of 4 months with rifampicin. I think we don't have drugs to treat latent TB with the shorter INH rifampicin regime. I was in the committee. I was instrumental in importing the rifampicin to India, and we are not able to do the rifampicin and I think this time we have to wait a long time for the rifampicin regime.
I think that is what I also said. We are both in the committee. So at least for the shorter regime for drug-sensitive TB, at least in India, is not being rolled out anytime soon. Yes, ma'am.
When you're going for the shorter regimes now, giving moxifloxacin and trusting that drug for 4 months regime, now it has cross-resistance with other quinolones. So use of levofloxacin, very wide use as a respiratory quinolone, would have any impact of unknown moxifloxacin resistance in the shorter regime of 4 months? What will impact it will have without knowing, because we are in wide use of levofloxacin?
I think you made a very valid point, madam. But I think the answer to that doesn't really come from the use of quinolones per se for a TB regime. It comes from the use of quinolones for pneumonia and other infections.
Yes.
I think we have a session on infections coming up. At least in India, quinolones are used left and right in urinary infection, respiratory infections. Quite convenient, cheaper drug to use. The reasons why people use it, and the widespread use of quinolones has resulted in extremely high levels of quinolone resistance even when a patient starts treatment for TB. So your point is valid. So when you're giving a moxiflox-based regime, you have to first test for whether from the beginning when you diagnose TB, whether the patient actually is resistant to moxifloxacin, to quinolone, and that can be determined only if you have those expert XTR cartridges, which again is not available. Again, it adds to the cost. So it's a very costly affair, everything put together.
Thank you very much.
Madam, to add to that, we have a high quinolone resistance. Fortunately, those who are levofloxacin resistant are maybe sensitive to moxifloxacin. It's a one-way resistance. That depends upon the gyre which resistance is there. Ideally, I think you have to go for a quinolone resistance before starting. But fortunately, there is no data on the moxifloxacin resistance in India.
In the interest of time, I think we are stopping this very interesting discussion. Thank you so much, both speakers, for the excellent lectures. We have tokens of appreciation and certificates for you.